Good evening and welcome to everyone. Thank you for joining us tonight for the Aspen Young Innovators Journal Club. Tonight, I have the esteemed pleasure of introducing our speakers to discuss the sacroiliac joint guidelines, a prevalent and important discussion on disease that affects many of our patients and has faced much scrutiny and controversy over the past few years. It's my great pleasure to introduce our speakers today. Joining us from our sister society, ISPN, we have Dr. Radwan Hussain, a pain fellow at UCL and Cleveland Clinic, London. Dr. Robin Mata, fourth-year PM&R resident at University of Miami and incoming interventional pain fellow at Rush University Medical Center in Chicago. We also have joining us our esteemed attendings, Dr. Buchanan at Spanish Hills Interventional Pain Specialist in Camarillo, California, and of course, Dr. Jordan Tate joining us from Atlanta, Georgia. So without further ado, I'd like us to just kick this off and get this important discussion started. So thank you for joining us and stay tuned in. And please keep all your questions saved for the end. We will have a dedicated Q&A session. So, Dr. Hussain.
Thank you, Dr. Chopra, for the warm introductions, and it's great to be here. So I'll kick this off by beginning to introduce the guidelines. So we're talking about sacroiliac joint disorders, and as Dr. Chopra mentioned, it's a very important topic to be discussing. It's very prevalent worldwide, so you have incidence rates of between 15 to 30% of the population suffer with SI joint issues. But more importantly, it's the way that they present. So it can be confused with lower back pain, which affects about 25% of the population, and it's the #1 presenting symptom to physicians worldwide. So with that in mind, with this overlap, there's a high degree of underdiagnosis as it mimics the other pathologies associated with low back pain. And it's important as it affects our patients' quality of life, and there's a wider economic cost and job sector burden as well. So the purpose of the development of these guidelines has been for clinicians and stakeholders really primarily to use for reference in the diagnosis, investigation, and management of SI joint issues. And in a wider scheme of things is to improve the evidence base in the pain community. Next slide, please. So as a brief overview as to how these guidelines were developed, I'm from an academic background, and it was very impressed as to how this was done. So it was essentially a large team, an MDT of different specialties from anesthesiologists, pain physicians, neurosurgeons, radiologists, and others who were divided into teams and essentially looked into the core topics that needed to be investigated in SI joint disorders. And from there, a literature review was conducted and an evaluation of the evidence that came up was undertaken. The interesting thing with these guidelines is there is a combination of the traditional evidence base, but also a combination with the expert consensus as well. And with regards to conflict of interest as well, it was rain checked with if there were any in any of the literature, then a third adjunct was used to look at the evidence base. Next slide, please. So the literature search looked at all the main databases from PubMed, Medline, Embase, Cochrane, and the ones listed there on the slides. It encompassed the papers from 2000 onwards, which is important because of the changes in the investigation management and the technology that we use as well. And then the level of evidence was marked based on the USP STF criteria, which had been modified for interventional pain studies, which I'll show you on the next slide. And from that, it was essentially, we were looking at the level of certainty as to how to give recommendations. And then a consensus was developed by each MDT team looking at the particular topic under review. And as mentioned before, an expert consensus when there wasn't sufficient evidence was also an option. And this is important because with RCTs and academic research, it doesn't always keep pace with real life practicing of medicine, and also trials are in controlled settings that are for the perfect conditions. However, as we know as clinicians, it differs in real life. Next slide, please. So just as to an overview here of how the evidence was graded. So if we look on the right side table here, there's three main categories, so high, moderate, low. High indicated there was at least one randomized controlled trial with a sufficient design that was interrogated thoroughly. Moderate means that there's either a control or non-randomized control trial or large retrospective series, and low evidence was primarily expert opinion rather than actual studies. And then if you cast your eye to the table on the left, which is the Aspen criteria for evidence quality, after the grading of high, moderate, and low, as the recommendations were based on this. So grade A to D here is in the top level, which is grade A, is suggestion to provide this service, all the way down to D, where it's not recommended to use this management plan, investigation, or diagnostic criteria. And then a statement would be produced on that, as Dr. Mato will show you later on, as to how best to go around any of the particular topics that had been researched. Next slide, please. So now getting into SI joint disorders themselves. So we'll start traditionally with the history, the examination, and investigation. So with the history, the main thing or the primary symptom is low back pain. And this low back pain generally radiates to the buttock, groin region, or the proximal lower limb. And the pain can be described as worsening on mechanical movement, things such as sitting and standing. Excuse me. The groin and upper buttock can also be involved. The important thing in the history is to try and identify some of the key risk factors associated with SI joint disorders. So I've listed them there. So from gait abnormalities, things such as scoliosis, previous surgeries, lumbar fusion particularly, or surgeries involving the sacrum, changes in body habitus, so obesity, or physiological changes such as pregnancy. And then comorbidities in the side of inflammatory spondyloarthropathies and connective tissue disorders. So the takeaway message from the guidelines here is that as with any patient, a thorough and targeted history, but the key thing here is to try and identify or keep an eye out for these key risk factors, as it will guide as where SI joint disorders come in your potential pathologies you're considering. Next slide, please. And then moving on to examination. So there's a list of different examinations that we've put down, and this was obtained from the literature. The important thing here is looking at these tests. So you've got from SIJ distraction, compressions, and the best thing for these is if you're not familiar with them, either asking someone or having a look, particularly on YouTube videos or other materials, to understand how they're done fully. And the importance of these examinations is actually the cumulative value of these exams. So it's not taking any one examination to help you diagnose, but it's looking at them together. So there's high specificity when you combine them. So the best practice statement here is that if out of these 5 examinations we've listed here, 3 or more are present, then it's highly indicative of SI joint dysfunction. But interestingly and important to bear in mind is that if it's less than 3, it doesn't completely rule out SI joint dysfunction. Next slide, please. And then the next stage in our journey is imaging. So imaging in SI joint dysfunction is primarily a rule out tool rather than a rule in. As similar cases in pain in general, one of the studies listed here that I've written in red, the asymptomatic, is that if you scan a large number of people, you will find what appears to be degeneration or changes, but not necessarily pain. And this was the truth here in this study. So 373 patients were looked at who had 65.1% of them had SI joint degeneration, but they were asymptomatic. So changes in scan are not necessarily related to actual pathology. So the mainstay of imaging here is a rule out, so ruling out of other problems. So things such as tumor, infections, fractures, spinal pathologies, or other red flag symptoms or issues. And it's also for the planning stage of interventions or surgery, or if a period of time has elapsed since the previous examination or investigation of this patient. Next slide, please. So the next stage is to then consider your diagnostic blocks here. So intra-articular SI joint injections is the gold standard. It can be done through just local anesthetic or a combination with steroids. The only real main difference is the duration that these will last for. So steroids will give you a longer duration of pain relief in comparison to local anesthetic only. The important thing here is to for the patient to keep a diary, track their pain intensity and also functional status or quality of life scores. And the general consensus is that if the degree of pain relief is greater than 50%, then it can be indicative of SI joint diagnosis. There's also potential to do a second confirmatory injection as well, especially if you're considering surgery or more invasive interventions. So as an overview, when you're trying to diagnose SI joint pain from the Aspen guidelines, the take-home message here is a thorough history, an examination where you're looking at these 5 factors here, if you can see in the table on the left. And if there's 3 or more of them, it aids your diagnosis. You then move on to imaging and diagnostic blocks. Imaging is for ruling out rather than ruling in SI joint dysfunction. And then a successful block with a pain relief greater than 50% is generally indicative of possible SI joint dysfunction. Next slide. So I'll now hand over to Dr. Mata to take over, and thank you very much.
Thank you, Dr. Hussain. I'm Dr. Robin Mata, and I'll be reviewing the best practice statements. So we're starting at conservative treatment, which is the keystone. It should always be considered and attempted before any interventional or surgical treatments in sacroiliac joint disorders. Table 4 gives us a great timeline on how to understand what conservative treatment looks like based on chronological presentation. So in the acute phase pain flare and SI joint, we want to avoid any triggering activities that could exacerbate the pain. Subacute, once the flare has stabilized, we're going to shift our focus to increasing activity, mobility, strengthening, stretching, all of those muscles that are surrounding the sacroiliac joint. That's going to be achieved through physical therapy, where they can address muscle imbalances, any posture abnormalities, and biomechanics. And then once we're stable, we want to continue to incorporate what we learned in physical therapy through a home exercise program. However, if the patient is still having chronic pain in the sacroiliac joint, that's when we want to look into interventional pain management options. And throughout this continuum, we can always consider non-steroidal anti-inflammatory drugs, NSAIDs, as treatment options to help manage pain. An important point that I recently learned from Dr. Buchanan is that external supports such as pelvic belts or orthoses are important to offer to patients and counsel them on, as it can help with pain. And make sure you document that in your notes, because that can also help coverage of interventional treatment should it be needed in the future. Next slide. So moving on to interventional treatments, let's assume your patient did not get better after at least 4 weeks of conservative care. SI joint injections are a mainstay procedure. They are diagnostic and therapeutic. They can be done with imaging guidance, so fluoroscopy, CT, and ultrasound, although notably CT is the most precise for sacroiliac joint injections. Contraindications that are absolute include malignancy and infection, and there are other relative contraindications to be aware of. Basically, it should always be performed under sterile conditions. Complications are possible, but generally mild. And it can be done under ultrasound in instances where you need to avoid radiation, such as pregnancy. Next. The takeaway here is that this should only be considered if the pain has not responded to 4 weeks of conservative treatments. Next slide. So I'd be remiss if I didn't comment on neuroablation treatments. Although less commonly performed now due to reimbursement issues along with other factors, previously these were very common. And so what I mean by that are lateral branch blocks, similar to medial branch blocks in the back, can be done for the sacrum. Look at the picture on the right. You can see the targets for this procedure. So it's the L5 dorsal rami and the S1 through S3 lateral branches. Important points here is that really, if you're going to do a diagnostic blockade, it should be done bilaterally. Single blocks can lead to false positives. And what you're looking for as a positive response is greater than 50% pain relief and improvement in function. This would be a precursor to radiofrequency ablation to at least 50% or 80%, depending on your patient's insurance provider. Next slide, please. And so if we were to perform radiofrequency ablation, the targets would be the same. The only contraindications are sacral fracture, malignancy, infection, and severe coagulopathy disorders. There are multiple modalities that the paper references if you're interested in learning more, like monopolar, bipolar, and multi-lesion. What we know about the outcomes is that the reason we target the sacrolateral branches is that you're 4 times more likely to achieve that 50% pain reduction at 3 months compared to placebo. Notably though, this is targeting posterior sacral pain. So if there's a portion of your patient's sacroiliac joint pain that is coming from the anterior region, this would not effectively control it. Next, the takeaway here is that if you do perform radiofrequency ablation, it shouldn't be done more frequently than every 6 months, and only if a 50% improvement in both pain relief and functional improvement are observed. Next slide. So the consensus guidelines does talk about regenerative medicine. As we all know, it's becoming more mainstream. Some of the more common injectates that you've heard of include platelet-rich plasma and bone marrow aspirate stem cell concentrate, also known as BMAC. The underlying purported mechanism here is that they are concentrating platelets and different growth factors so that we're promoting tissue healing, increasing tensile strength, and enhancing cellular activity. Unfortunately, though, there's not a lot of high-quality peer-reviewed data at the moment to make a strong recommendation. And so in that context, the best practice statement for regenerative medicine is that it should only be considered when other validated treatments are either ineffective or contraindicated, or your patient has no desire to pursue more interventional procedures. Make those decisions on an individual basis with the best existing literature at the time to support your decision. Next slide. So that kind of brings us to the more definitive treatment option for refractory SI joint pain that hasn't responded to interventional treatment or conservative care, and that is minimally invasive fusion. We're starting with posterior approach. This is usually performed prone with either local anesthetic or sedation. It can be done with general anesthesia, but isn't necessary. It's a small incision posteriorly to access the SI joint, and we're placing 1 or 2 allografts. So if you look at the picture on the bottom left, it gives you a step-by-step of the procedure's main points. So first you'd be gaining access through the large pin and then introducing a tissue dilator to create a working channel. Then you decorticate or take out bone to make a pocket for that allograft to fit in, which is the bottom left picture. And then once you've created that pocket, you're going to be inserting a allograft, which is shown in blue in the picture on the right, that contains demineralized bone matrix that will help that decorticated bone grow into the allograft, so you get a nice fusion across the joint. Next, what we know about the outcomes is that we do see good pain reduction and improvement in disability up to 12 months post-procedure, and there's generally low procedure related complications, which we'll talk about a little bit more in a few slides. Next. Alternative approaches, we want to make sure that we cover so you know what's out there and what's available. So probably the more common would be the lateral minimally invasive SI fusion. You can see that in the picture on the left. So here we see 2 to 3 implants that are coming in from lateral to medial, covering the ilium and the sacrum. This is, compared to open surgery, it is less invasive, there's less muscle and ligament disruption, and it is shorter operative times with fewer complications compared to a major open surgery that would be performed by our orthopedic colleagues. Again, we do see improvements in pain and improvements in disability up to 12 months post-operative and decrease in opioid use. The other approach next is the posterior oblique, and it's similar to the lateral, but a little bit more angled. And so instead of coming straight lateral, you're going to start lateral to the PSIS and take an angle trajectory into the sacral promontory. Both of these would be performed under fluoroscopy. Next slide. So while the paper doesn't give a definitive stance on which technique is more favorable over the other, there is emerging data that can help guide your clinical decision making. There was a paper that was recently published in 2024 by Kolodny et al. Titled Secure in the Journal of Pain Research. It was a multi-center prospective clinical study looking at outcomes for posterior fusion in 122 implanted patients. And while we found what we already know, improved pain and disability at 12 months, when we compared the total adverse events and serious adverse events to prior studies that had been done looking at the lateral approach like IMEA and Insight, there was a significantly lower amount of overall adverse events. Some of the reasons that are purported why there's lower adverse events with the posterior approach is procedural advantages. So this can be done under general, not under general sedation, but just light sedation or monitored anesthesia care. It can be done in an outpatient setting versus a hospital, so potentially less risk for infections. And finally would be the approach, right? So when we're doing a lateral approach, there is a higher risk of neurovascular injury due to the muscle dissection and the anatomy associated with the procedure. Next slide. The takeaway for minimally invasive surgical treatment is that this should only be considered in patients who have failed 6 months of conservative treatment and had at least or over 50% pain relief from an image-guided diagnostic SI joint injection. Next slide. The wrap up here would be if you're having any difficulties ever remembering or navigating what is the SI joint dysfunction treatment algorithm for an interventional pain physician, there's a great paper by Dr. Falowski et al. Where you can follow the joint injection here. Now I'll turn it over to my colleague, Dr. Francio.
Thank you, Dr. Hussein and Dr. Mata, for such a great presentation. I want to take a brief moment here to thank our sponsors, PainTech, of today's webinar. I also want to encourage our audience to ask questions on the question box to make this a more interactive discussion. With that said, please, Dr. Buchanan, take it away with the more interactive case discussion part of this webinar. Thank you.
Yeah, thank you very much. I just want to also acknowledge PainTech. You know, they were one of the first movers in the posterior fusion space and definitely put the time and the money to do the research, a lot of which serves as the basis of a lot of these Aspen guidelines. So we appreciate your support. And with that, Dr. Hussein, Dr. Mata did a great presentation on kind of how to diagnose the SI joint and the treatment options. I'm gonna give you an overview of how I go about treating SI joint in my own clinical practice. So I have a couple cases here to talk about. The first one here, we have a 72-year-old female with a history of hypertension and diabetes who presents with low back pain that radiates into the buttock for 20 years. Pains were sitting to standing, bending,
no prior surgeries. Again, as Dr. Mata mentioned, they've had to have failed a lot of these treatment options. So this patient's had physical therapy, medication, bracing, epidurals with moderate relief. And on physical exam, they had tenderness over the lumbar paraspinals and SI joints, as well as 3 out of the 5 provocative maneuvers. So when going through insurances and everything, it's very important to document all of these things, everything they've tried and failed, including bracing, physical therapy, and any other injections. And then also the 3 out of 5 provocative maneuvers is also key for that. Next slide. As well as the CMS guidelines want you to order imaging, as Dr. Hussein mentioned, to rule out other pathologies. So they require a MRI or a CT of the lumbar spine, an MRI or CT of the sacrum, X-rays of both the lumbar spine, the SI joints, and the hips as well. So make sure you have all of those images included as well for that. So as you can see here, the reason why the SI joint, in my opinion, is undiagnosed is because there's so many pain generators around this area. As you can see on this MRI right here to my left, there's modic changes, there's a disc herniation in L5S1, patient has multifidus atrophy, patient has lumbar facet arthropathy. On the right, there's osteoarthritis in the SI joint. So how do you determine which way to go for these patients if they present with low back pain? Because there's all those pain generators. So that's why taking a history and physical exam is so critical in this diagnosis for the SI joint. So typically, if they have 3 out of 5 provocative maneuvers, and we've ruled most of the other things, I'll go ahead with an SI joint. The other thing I want to mention as well is look at your CT scans as well for the sacrum if you are going to be doing a minimally invasive fusion, because every SI joint is kind of like a fingerprint. They have their own unique morphology. So make sure you're looking at your own images as well to make sure there's no dysmorphisms or anything like that. Next slide. So for this patient, since the physical exam findings were 3 out of 5, I decided to go ahead and order intra-articular SI joint injections for her. Now, the way I do my SI joint injections is I go ahead and do a contralateral oblique injection targeting the middle third of the joint. So the reason why I do this is see first if they are a candidate for an allograft in the middle third of the joint. Because if I can't access it with a 25 gauge needle, there's no way I'm going to be able to put an allograft in there. I typically put in a combination of 1% lidocaine and either 40 milligrams of Kenalog or Depomedrol. CMS guidelines state it has to be under 2 cc's per SI joint, so make sure that's under 2 cc's for that. And looking at this view, this is the contralateral oblique view. I typically guide my needle right where the SI joint, the posterior and lateral posterior and anterior portion of the SI joint meet, and I dive into the posterior SI joint. You also want to get a lateral too to make sure that your needle tip is deeper than the posterior part of the sacrum as well. So I'll do one, and typically for insurances, you need at least 75 to 80% relief if you are going to repeat it. So just make sure the patient is getting that much relief. I'll do one with steroid first. If they're getting 6 months relief or more, great, I'll repeat that again. If it's less than that, then I'll have the discussion with them. Do you want to do a diagnostic with lidocaine only to go ahead and pursue the SI joint fusion? Some insurances do allow for radiofrequency ablation. However, this is obviously going away too as well. So I'll offer them radiofrequency ablation if the insurance allows it, or the SI fusion, which is the permanent fix to this. Next slide. So this patient elected to go ahead with the SI joint fusion, and I put in the link queue by Paintech here on the right SI joint. As you can see here, I went right at the bifurcation of the SI joint, making sure that it was deeper than the posterior part of the sacrum there. And she did fantastic with this, 80% relief. Next slide. She did still have pain on the left side as well. So sometimes it resolves. Sometimes the worst side resolves with it because the other side's compensating. So they do great with that. But in this one, I think I did this one about 6 months later. There's a global period of 3 months, so just keep aware of that. And she did great with that. She got 80% relief, and this has been 2 years out right now, so she's doing fantastic with this. Next slide. My next case, this is a little older gentleman here, 86-year-old male with history of hypertension, a lumbar decompression, complicated bilateral foot drop with persistent low back pain. He had a revision as well. So lots of surgeries in the back. Now presents with right low back pain for about 3 years. That's non-radiating dull. Again, document, make sure physical therapy, bracing, medications. On physical exam, he had provocative maneuvers positive as well as facet loading. So for him, I asked him which maneuver reproduced your pain the most, and he said the provocative maneuvers did. So that's why I decided to go with an SI joint injection. I did get a DEX scan on him. I don't give it for all my patients, but if they're elderly patients, it's typically good to get a DEX scan. Osteoporosis is not a complete contraindication. You just have to be careful when going into the joint. I highly recommend a blunt needle tip for this because you could get a false positive into the joint if you're using the sharp needle because you can pierce the sacrum and ilium pretty quickly and easily with osteoporosis patients. Next slide. So again, on the imaging, anytime I see a patient with hardware in the lumbar spine and having low back pain afterwards, I'm immediately focusing my attention to SI joint pain. Typically, they have that with the adjacent segment disease here as well. Next slide. So he did elect to go with the injections, the SI joint injections. He had 2 injections with over greater than 80% relief, and he wanted to do the SI joint fusion. Now, the advantage of doing the posterior approach, like Dr. Mata said, is you don't have to be under general anesthesia. You can do this as an outpatient clinic. So for your elderly patients with some comorbidities, it's easier to do under MAC. This patient did great with the SI fusion. This is a CT scan about 3 months after. There's no really bridging yet of the SI joints fusing in there, but it's in the correct place and he's doing well with that. Next slide. So this is just a summary overall of the Aspen guidelines. Again, just to wrap this up, you need to have 6 months conservative treatment, which by the time you see them in the office, they probably have had that. Greater than 50% pain relief on the diagnostic injections. Again, check with your local guidelines. It's typically 75 to 80% relief with that. And then in terms of the studies, like Dr. Mata mentioned, really look at them in terms of when you're choosing to decide which approach to do or which company to partner with, it's really important to look at the data for this. Make sure they do have data published for this, biomechanical and clinical data, that it's, ideally it'd be multi-center randomized trials, but see what they have there or if they're planning on doing that. So that's critical for the space and for our patients as well. Next slide. And I think that wraps up my section. I'm going to turn over to Dr. Tate to talk about her experiences with her patients using the SI fusion.
Awesome. Thank you, Dr. Buchanan. And again, thank you to Aspen for inviting me to speak this evening. And what a wonderful presentation and discussion this has been so far. I want to pivot a little bit and talk about how SI joint fusion works in common private practice. So I am Dr. Jordan Tate, and I work at Southern Pain and Spine in Atlanta, Georgia, and we are an outpatient interventional pain group and practice in ASC-based setting. And so working with a myriad of insurances as well as our local Palmetto MAC, we have had, some various issues over the years with SI joint fusion. For any of those of you who have been keeping up, it's been a bit of a roller coaster ride with the AMA coding and the changing in coding, and with various policies across our insurance partners changing regularly. So I'm presenting here a patient. I call him my policy advocate. So this is a 72-year-old male who came to my practice many years ago and carried a diagnosis of chronic SI joint dysfunction. And he had, previously been treating with chiropractic care and was, going for weekly adjustments and felt very confidently that his pain was the SI joint as the primary pain generator, because he would get a lot of relief historically from these weekly adjustments, and his chiropractor was, discussing with him about how there was palpable subluxation of his SI joint. So when he came to me, of course, we did some initial evaluation and scanning, and he really didn't have any surgical findings in his lumbar spine. He had some mild to moderate spondylosis and stenosis, but it did appear, based off of his physical exam, that the SI joint was his main pain generator. So after undergoing some diagnostic SI joint injections and then ultimately transitioning to a therapeutic protocol where he was getting fairly regular, Q 6 months or so, steroid injections. Over time, he felt like he was getting waning results with his steroid injections, and so we opted to switch to sacroiliac joint RFA. This would typically provide him about 9 months of relief. And so over several years, he was receiving RFA 1 or 2 times a year. With pretty great results, typically somewhere in the 90 to 100% pain relief for many of those months, and usually followed by about 50%, and then he'd be ready to repeat again. And so this went on until, unfortunately, as many of you recall, several years ago, we lost coverage pretty much around the country for SI joint RFA. I think there's still some pockets where certain Medicare MACs are covering even still SI joint RFA, and then of course certain work comp and personal injury type cases. But generally speaking, SI joint RFA had fallen out of favor and certainly was not being reimbursed. And so for this patient, we started talking about SI joint fusion, and he was interested. He was denied, however, on our first submission. It was deemed experimental and investigational by his insurance coverage, and he had a Medicare replacement plan. And so he decided to self-pay for an SI joint RFA, and he did this a couple of cycles and continued to get good relief. But of course, over time, he grew weary of the high cost, knowing that he was paying a lot of money for his insurance, and knowing that his if he had regular, type Part B Medicare, he would have coverage and access to this therapy. And it was frustrating for him. And so we decided to, again, submit for an SI joint fusion. And he really wanted to go with the posterior approach with the allograft after doing a lot of research and speaking to many people across our practice, as well as with Pain Tech. And so he read all the papers. He was very directed by the evidence in the space. And so ultimately, his procedure was denied. It went to an appeal, that was denied, and went to a peer-to-peer, which was also denied. And then, so finally, our fourth level of appeal was for him to go in front of the ALJ, the law judge, and this was scheduled. He was armored with giant binders this big of medical documentation, letters from his chiropractor and physical therapist. I wrote several letters. He had all of his medical records. He had, all of the conservative care thoroughly documented that he had undergone, as well as various policies across the country with positive coverage for the 27278 code. And so he was offered a virtual ALJ hearing, and he instead decided to go in person to New Orleans and meet with the judge and present all of this information. And, with somebody who is so passionate about this, really falling on the sword for all the other patients and going forward with advocacy. Ultimately, there was a policy change with this particular insurance company, and it was turned into a positive coverage for the 27278. And so the good news here, next slide, is that after many, many years of dealing with SI joint pain and dysfunction and trialing all of the conservative therapy options, he was ultimately implanted. These pictures are from earlier this spring. And he is reporting 90 to 100% depending on the day. He's extremely happy. He's messaged almost anybody who's ever worked at Pain Tech on LinkedIn to express his appreciation. So this was a big win for our policy advocation. And I encourage you to fight the good fight with your patients, because sometimes it can turn out positively. So that's this patient. Next slide. I have a second patient to present. And so this lady, I'm calling her Brittle Betty. So which is not a HIPAA violation, it's not her name, but she's an 81-year-old female, and she is probably 90 pounds soaking wet. She has some pretty significant scoliosis and presents with a very significant pelvic obliquity. Next slide. One of her goals was to go to Europe. And so, as Dr. Buchanan was saying, we could also call her like little red herring, because you have all of these pain generators and patients present to you with a, scoliotic spine with multi-level degenerative disc disease and disc protrusion and, stenosis with spondylosis and modic changes. And, you're looking at these MRIs and you're saying, where do I begin? And the answer really lies in good physical exam. And so, especially with this lady, one of the things that was super interesting was because she was so tiny and because her scoliosis was so pronounced and her pelvic obliquity was so impressive, when she would do her Fortin sign positive, if you didn't actually lift her shirt and look at her, it appeared as though she was pointing to her like L4 area, because it was above her waistband on that side. And so in reality, you had to, actually put your hands on her, do a good physical exam, and recognize that in her, that Fortin sign positive was actually below her L5, and she was pointing to her SI joint. In addition, she had her provocative maneuvers were positive. The other side of the screen, what I'm showing here and why I call her brittle, is when we first presented the idea of doing SI joint fusion after we had, of course, had positive diagnostic blocks. One of the concerns was that, she's very petite, as I mentioned, 81 years old, and what was the health of her bones? Does it make sense to offer an SI joint fusion to somebody who is likely to be osteopenic, osteoporotic? And so we did track, some of her DEXA scores, and initially she was kind of borderline and tracking low. And so we did recommend that she get with endocrinology and work on her bone density. And so she kind of, followed all of their recommendations and did some weight-bearing exercise and got on the right supplements and the right bisphosphonate. And ultimately, she improved her T-score and got to the point where she felt, we all felt like it was a good idea to move forward with posterior SI fusion. And so, this is a patient where, again, that posterior approach mimics the same approach that we take with our percutaneous injections. And so it's a more familiar space, and you can, often confidently say, I'm going to be able to get into this space and not create any damage to any of the tissues. And so when you're dealing with a more brittle patient, somebody who might have borderline osteoporosis, and you're thinking, is this an appropriate candidate for, a lateral fusion, or using more of a titanium screw or graft implant? It may give you some pause, and I think, the posterior allograft is ultimately more conducive to a patient such as this. And so that's what we went with. And so she was implanted. This was a couple years ago, but she ultimately was sending us amazing pictures from her European vacation, and she was hiking in the Swiss Alps. She was an extremely motivated and active patient, despite her scans being quite offensive. So I think that's all I have for those two patient presentations. Next slide. Thank you.
Thank you to everyone, Dr. Tate, Dr. Buchanan, Dr. Hussain, Dr. Mata, for a wonderful discussion, really impactful cases. And now we'll move on to the Q&A. We'll start with a technical question. First, are we potentially causing adjacent segment disease in the lumbar spine in patients with no prior fusion?
Yeah, I'll take that question. I mean, that's a great question, because you're technically fusing it, right? So with the posterior fusion, with the single allograft there, you're doing two things. You're distracting the joint, creating ligament ataxis to stabilize it, and you're also fusing the joint as well. So, the natural SI joint has about 1 to 2 degrees or a couple degrees of nutation, counter nutation. So the reason why you have SI joint is you're either hypermobile, too many degrees of rotation, or immobile, right? So what we're trying to do with a posterior allograft is bring it back to its pre-disease state. And if you look at the biomechanical data on this, specifically with PainTech, and compare it to the biomechanical data with the lateral fusion, which is considered the gold standard, you still have a couple degrees of nutation, counter nutation of that. So you're not completely fusing it. It's not a complete hard fusion where you have no movement around the joint. So I think because of that, you see less of the adjacent segment disease. Now, do I have patients that need facet injections after? Yes. Now, do they already have facet disease before this? Probably. So they may have multiple pain generators as well. And once you knock out the main one, they may have other ones that creep up as well. Anyone else have any comments on that?
Yeah, I mean, I think part of that is, when you're doing your workup for the patients and looking at, the multitude of imaging, assuring that, they aren't already dealing with very significant L5-S1 degeneration, perhaps, or a moderately severe hip arthritis. Those are things to take into consideration when you're considering that you are immobilizing or fusing this SI joint, that you potentially are shifting force, to these other areas, and that potentially you could be exacerbating maybe the degradation anatomically, but at least, the pain related to the shift in forces. And so it's something to be cognizant of and to be thoughtful and mindful of when you're taking your patient as a whole. But it's not something that I'm particularly seeing in my patient population, right? I mean, again, I'm not taking patients who have moderately severe hip OA regularly to SI fusion, right? I'm typically kind of excluding some of those patients, but what I'm not seeing is, a cohort of patients who have had a posterior allograft fusion, for example, and then, 4 or 5 years down the line, they're all needing lumbar fusions that they didn't have before, or needing a hip replacement that they didn't need before. I'm not seeing that.
Thank you. And we actually have a follow-up to that same question. So, and I quote, "My concern with allografts, especially in the elderly population, is that we are not really seeing bony fusion happen across the joint, at least not for a very long time. Are we merely obtaining relief from distraction of the joint, and should therefore worry that it will fail later on in the patient's life?"
Yeah, I mean, that was my second case presentation. I had an 88-year-old patient with, comorbidities and had multiple fusions. And as you can see there on the CT scan after 3 months, you didn't really see much bridging yet, but he's doing great. So the question is, we don't know exactly, the answer to that. There's many patients that haven't properly fused that are doing great relief with this. Do we know exactly why? I don't believe so. Is it the distraction? Is it the ligament ataxis? Is it just everything resetting that area? You know, that all needs to be worked out. You know, there needs to be more long-term studies on posterior SI fusion for this to see. But this patient has been 2 years out and still doing great. I see him maybe every a couple of months to refill his Lyrica, but other than that, he's doing great.
Yeah, I mean, I would echo that as well. I think you know, there's a lot that we, as much as we have learned and do know about the space and you know, these different approaches with fusion, what we don't know exactly is why one patient responds well to a certain approach and maybe, you know, ultimately doesn't respond well over time. Is that, you know, I think we've seen in both cases where patients do have significant fusion across a joint and they aren't getting good pain relief, and then they can be salvaged. You know, if they have had a lateral approach, you can salvage them with a posterior approach in some cases. There's, you know, evidence in that space. And then the opposite is true as well. You know, if a posterior approach does fail after a few years, maybe this patient is more appropriate for a lateral approach. But we don't have any of these, you know, longitudinal or head-to-head studies to really parse out, you know, this high detail of patient selection. I think what, you know, a lot of people kind of feel like, you know, maybe it's more of a spectrum, and the more minimally invasive thing to do is to, you know, try a posterior allograft first before you're going, you know, to a metal implant or maybe you know, a more invasive lateral approach. Potentially that, you know, that may be where we're headed in the future, is that we see this as more of an algorithm and kind of like the spectrum of treatment.
Awesome, thank you. We have multiple questions here, so I'm gonna jump into the next one, and I quote here. I have been following data and trends on SI joint fusion for a few years now, but have been reluctant to get into this space. A big part of this reluctancy has been my observation that many of our SI joint injections are not in fact intra-articular. They are more intraligamentous injection, considering more diagnostic. If not, do payers require diagnostic injection to be intra-articular as proven by the intra-articular contrast flow? Question mark. I think it kind of goes along the lines of what Dr. Buchanan was talking about, doing his injection approach, kind of like away from the inferior aspect of the joint and more so into the middle part of the mid-body approach. So would you care about commenting on that, please?
Yeah, absolutely. I think you absolutely need an intra-articular approach for this to diagnose it. And again, I didn't show there, but you should confirm that with a lateral view. So your needle tip should be, you know, past that posterior sacrum. So you have the arthrogram there, then you also have proof that your needle tip is past there to confirm intra-articular approach. And that's what the CMS guidelines, you need to have 2 diagnostic intra-articular SI joint injections of, depending where your local guidance is, but for me it's 75 to 80% relief before we even consider a SI fusion of any kind for that.
Yep, and many of the guidelines or, you know, insurance requirements do delineate that you need to have contrast enhancement unless there's a contraindication to contrast, and also that there are volume maximums. So, you know, Dr. Buchanan mentioned 2 cc or 2 ml. I think, you know, and there's some others that say 2.5, but in general, you know, to combine with the contrast and your ultimate inject date, you want to limit your volume so that you aren't creating any spillover into the posterior ligaments and creating a false positive as well.
And just to add to that, you're not going to get, you're not going to get a perfect arthrogram every single time. A lot of these SI joints are so degenerated that the capsule has been, you know, pretty muddled and stuff. So you may have a little bit of spill out there. That's why, like Dr. Tate said, you need to keep the volume to a little bit there.
And our final question for the evening. As a predictive factor for benefit of SI joint fusion, do you use the Sacroiliac belt in addition to the SI joint injection with positive predictive feature for proceeding with minimally invasive SI joint fusion?
I mean, I never have. I do recommend Sacroiliac or SI. I mean, I think Sacroiliac is a brand name, but SI belt bracing as one of my conservative measures for most patients. I find the tolerance and compliance to be a little bit on the low side, but certainly if you do offer it to most or all of your patients, you will capture a few patients that's really all they need, you know, if they can be compliant with an SI belt. I've never thought about the importance of combining it with a diagnostic injection to further get a positive predictive value out of my injection, but that's something to think about.
Yeah, I mean, that's a great question. I haven't done that as a predictive factor for that. You know, the gold standard is a intra-articular SI joint injection. There's no, you know, there's no radiologic graphic findings to point to it. So yeah, the gold standard is the joint injection.
And with that, we are concluding for the evening. A huge thank you to all our attendees. A massive thank you to all our speakers and to our sponsor, Pain Tech. Thank you again for joining, and we hope to see you next time.
Again, thank you, PainTech, for the sponsorship, and we certainly hope to see everyone in Miami in July for a celebration, a lot of learning, a lot of good experience and networking. You can scan the QR code here to make sure that you're registering for our annual conference, and we look forward to seeing you there. Please come early on Thursday. We have the Young Innovators event on Thursday night, and make sure that you live on Sunday afternoon, because we also have the Young Innovators panel on Sunday morning. So you come in early and you leave later, and then we'll have a good time, okay? And I also hope to see you guys in London for our ISPN conference, and we have Rod here as our friend from across the Atlantic representing us. So as our first Aspen ISPN event combined, and looking forward to this great event. Thank you, everybody.